Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric O'Kelly. This week, we are in Zermatt, Switzerland, for the Big Sick Conference, part of the Air Zermatt team, and we have 4 faculty this week, and with me is Dr. Ella Corrick, Dr. Sean Bilodeau, and Dr. Tom Mallinson. Welcome to the TBS. All of us have been here before, so this is not new, but tell me, how is it going this week?
Well, I guess, so the first thing to say is the 3 of us have just come off the hill from running essentially a compressed, prolonged field care exercise workshop. So we have all literally just jumped in the shower, come down here to have a chat. So I guess the thing in the front of our mind is how to provide that good quality education in a compressed space of time, which I suppose is the same across TBS, right? The talks are fairly short. They have fairly complex physiology or medical interventions. So I suppose our workshop embodied how do we put all of this intense learning and knowledge and information across to a very diverse audience in a very short period of time.
Yeah, and for the prolonged field care, it's a challenge because we only had 3 hours for the workshop, which isn't really very prolonged field care. And, we were translating that from the AEC course, which is 5 days, has a 12-hour exercise on the last day, and trying to abbreviate that into 3 hours. I think it was difficult to know how much to try and preload our participants with an idea of how it was going to run or with information versus how much to just kind of let them take learning points organically as they came. And we went with a more organic approach. I think it worked really well, but it's definitely made it more stressful for me going in because I was more nervous about how it was going to work out because it was quite reliant on our participants being up for it, getting stuck in, listening to each other, being open to proctors kind of just putting in gentle facilitation rather than us stopping and giving like educational talks. I think it did work really well because we ended up with a really good group of people. People seemed happy at the end, but yeah, that was something that I was stressed about, I would say.
I think it was awesome to be able to have these people that are at a conference talking about high acuity calls like ECMO and Reboa, and then we're talking about hypo-raps and lowering off a mountain, and they were totally engaged in that. And I think that having CoROM like bring something that's high acuity but in a totally different sense was really cool to see people get really excited and really to go from a talk about like mass casualty in London, listen to this morning, to like, now we're going to talk about hypo-raps, but we're actually going to go to the snow. And to see people engaged in both of those things is really awesome to see that. I don't think you see that in a lot of spots.
Yeah, and the example of that is Tom was saying, he was talking to one guy whose background is cardiac anesthesia, and he was saying, they use therapeutic hypothermia in the most controlled setting you can imagine with proper core temperature monitoring throughout. They are micromanaging that whole process. And he said it was really interesting for him kind of actually experiencing the complete polar opposite of that, of dealing with real hypothermia. We were actually in the snow. We did get the casualties down to underwear only, more or less trauma naked in the snow, and they had to keep them warm, and it was quite hard work.
I guess the other thing that you guys are saying there about those challenges of education, and it's a very diverse audience at Zermatt. Clearly, at TBS, they're here for a reason. Like they're motivated, they're interested, they want to learn. But so we were very lucky to hear Sean speak about challenges around education and around educating different professional groups when different professional groups approach a problem from a different mindset and a different learned culture of problem solving or treating or managing a patient. So I guess coming back to our workshop, not that we just need to talk about that, but there was a very diverse group of paramedics and anaesthetists and ER doctors. And I guess we experienced firsthand that challenge of a multinational, international cohort of mixed professional groups that we then threw on a mountain and tried to teach them something new and different. But I think that's kind of embodied what you were saying about the challenges of educating different professional groups and bring them all to the same endpoint, but from a different pathway.
And along the same lines, like what conference brings paramedics, cardiovascular, anesthesia? We have pre-hospital docs, and we had it was a nurse that gave a talk today, and so like what. It's so hard to find that. In the States, most of our conferences are kind of doc only and medic only, and so for me to see like this broad group. And it's just really interesting and to hear the talks that kind of go again from like mass casualty to ECMO to palliative care. And so to have all of these world leaders speak to a bunch of different people from different professions is really interesting. And it's small. And so what's cool is that I was walking down the street yesterday with like a crepe in my hand, and someone was like, "Hey, you gave that talk. Can we chat?" And so like it's just because it's so small and everyone's so approachable, I feel like you get to really know folks if you want. I mean, we chatted with a woman that's going to talk about space medicine, like at the bar. And so it's so informal. I think that really helps.
And I guess coming back to what you said in your talk about, I think it's very easy to assume that if you put a paramedic with a doctor, the paramedic's there to learn from the doctor. But like, that's not always how it happens, because paramedics have their own specialist scope of practice. So that learning goes both ways. Or in our workshop today, prolonged field care, some of that key core learning is nursing care. And that's an area I'm not an expert in. I'm not a nurse, but we have nurses there. We have a variety of expertise and specialties. And that nudge towards, hey, you might be the best anesthetist in the world, but what do you know about providing nursing care? Because nursing care prevents secondary infections, it prevents pneumonia, it prevents all these things that we kind of take for granted, right? So I think for me, that's the benefit of having that mixed conference of mixed professions.
If you've noticed, we have a bit of a background. We're at the pub in a hotel that is several hundred years old. I was sitting in a chair yesterday, and Patrick, one of our faculty, said that chair is older than the country I was born in. So there's a lot of history here, and it's a fantastic location. But we are in a pub, and we are going to have a wee bit of a background noise. But so we talked about the PFC exercise. What was some of the lessons learned, do you think, that these HEMS anesthetic docs who've never done austere medicine?
I think the burrito wrap for hypothermia was probably the key learning. It was very interesting. So we provided laminates describing step by step how to create an effective burrito wrap. And even looking at that, and these are very clever people who are much better at their specialty than I ever will be. But their instinct was to do what you would do indoors, which is just to put one layer for comfort, so one of your air bases, under the patient for comfort only, and then to cover them with layers of warmth over them, which was not creating an effective vapor barrier. And also our patient was being transported on a sked, which for those who don't know is essentially a thin plastic sledge stretcher, and it has almost no insulating properties at all. It is incredibly cold to lie on one of those. And so our patient initially only had one layer between them and that sked, and was still wearing some wet clothes and got cold very, very quickly. So I know our group then had to reevaluate, actually, what are the effective layers? Can we create an effective vapor barrier? Can we put more insulating layers under as well as over our casualty, and so on?
How did the inflatable mattress do?
It worked well, but I would say one challenge was on a sked, which is a slippery surface. I think one challenge is on the sked as a slippery surface because it's quite narrow. We were taking ones that are portable. Then the casualty ended up with only half her body on it after movement. But then that's an issue again of an effective burrito wrap, which could have kind of tied it to her if it was really wrapped into her.
It's meant to be inside the vapor barrier.
Yes, which we worked towards.
I think we did a good job. It was nice to let the students kind of process that on their own, and then have the folks that volunteered to be casualties were amazing, and they were like, no, I'm actually cold. And so to actually like inject some reality into that sim, I think gave people the ability to really like learn from it.
I think one of the things I really liked was from the educationalist point of view of running that. Sean, at the end, you did, so we went around to the participants, but your approach was, tell me something that surprised you or that was surprising. So I think that question of what was surprising to you is kind of a nicer way of saying, what's one thing you've learned, which I think we use so much in education, and people can feel pressure to say something, but you're bringing out the same answer, but in a more interesting and dynamic way. And you don't have to put your hand up and say, I've learned something. You can just be like, oh, it was really weird how this happened, or like really surprising when this happened. And you don't have to put yourself on the spot and say, I learned something.
Yeah, I think like it was. I think being able to have the folks kind of process that was interesting too. And someone, it takes so long to get them down. We only had them go like 50 meters, and they were part of it. They were, like using ropes, but for the most part, and I think people are like, wow, this is just a lot of work to just exist out there and move one person. And so I think that was one of the things that they said that, again, brings this idea of, we're talking about every resource imaginable and a lot of these talks. And we go like, oh no, you just get your backpacks. And to realize that the acuity is the same based on different reasons.
Yeah, it makes me think of working in hospital setting. Sometimes you get handovers from paramedics to emergency department staff who have never worked pre-hospitally, and you see this total disconnect from the reality of what the paramedics have dealt with. I have this really memorable one where, so this was when I worked in the Western Isles, and we had a patient who had been in a motorbike accident. They'd come off their bike onto the peat bog. And for people who have never traversed a Scottish peat bog, you take 3 steps on what seems like solid ground, and then suddenly you're up to your waist in black water. So these paramedics had to go out, and it was maybe like 15-20 meters. It was maybe 15-20 meters from the road. They had to extricate this guy from deep bog and then carry him across onto the road. And then from there, they were like 10 minutes from the hospital. But the whole extrication process took them about 90 minutes, even though they weren't extricating him from a car. He'd fallen off his bike, and they carried him in. They were absolutely sweating bucket loads. These paramedics, they were exhausted. They were covered up to their waist in mud. And one of the emergency nurses said, why haven't you given the TXA yet? And you could just see their faces.
Yeah.
It's like, we have been working so hard.
We've rescued this dude.
We stopped him from drowning.
Yeah, exactly. But I think that's another benefit of the conference, right? Because we've got that broad scope here of people who are doing the highest end critical care innovation, and the people who, like myself, for example, I'm pre-hospital care in Scotland. It's not necessarily cutting edge, but that mix of frontline pre-hospital people and the folks in the big tertiary centres with lots of money to be doing the experimental ECMO and the partial Roboa, and maybe that stuff will filter down to all of us, but having that discussion between those two groups, I think, is hugely valuable.
A lot of that stuff is going, like this ECMO, Roboa, they're talking about doing it in the pre-hospital environment. And so I think it's good for those folks to get out there and do it and realize that you can't just make the streets sterile. And there's a lot that goes into the scene and transport. And there's not just like a button that, you just teleport from the scene to the hospital. So you want to do pre-hospital ECMO, there's EMS involved in that. And I think to get people out of the hospital and learning what's happening before they actually get to the hospital, it helps, even if you're doing Roboa or not.
Last week we had our MEM conference in Malta, and it was up last weekend. What do we have? So we did this back to back, and I'm sure it stressed us to get from one to the other. It's interesting to see the difference here and Malta, because Malta, obviously, we're focusing on austere medicine, and here we're not. But because we're in this valley, it just keeps coming up, doesn't it?
Mm-hmm.
I think I have to admit, on average, and this isn't me just saying it because I'm CoROM faculty, on average, I preferred the talks at MIM. I found them more engaging because they were more directly applicable to my practice, because they were based on people in austere or remote environments where you don't have all the resources. Whereas the talks on ECMO and Roboa, whether in hospital or pre-hospital, are totally irrelevant to my current practice, because I believe there's one ECMO centre in the whole of Scotland. I am never, ever going to... The only circumstance in which I'm going to really refer a patient for ECMO in my own practice is hypothermic cardiac arrests and avalanche cardiac arrests. from mountain rescue. Otherwise, ECMO might as well not exist for my practice, and likewise for Reboa. So those talks are scientifically interesting, but they don't kind of catch me in the same way. Although there are still talks that are relevant to all of us at TBS. Like Sean, I really genuinely really enjoyed your talk about how we educate paramedics when we're kind of training them up to skills that have historically been physician skills and that rely on like a deep understanding of physiology and anatomy to kind of work. That's how all physicians have trained to do those procedures historically, but we've then started trying to train them without that full background. And how do we bridge that gap? And how do we deal with the difference in just volume of clinical exposure that the two professional groups get in their training as well? So that was really interesting. And there are people here who are fundamentally just really, really cool, fascinating people. Sean mentioned we spoke to someone who's going to be giving a talk on space medicine, which is Jennifer Dow, who's speaking tomorrow, and I'm really looking forward to her talk. But we just got chatting to her at the bar. She's got previous like search and rescue experience. I believe she was president of was it WMS? Yeah. She's looking into research of improvised tourniquets for climbers. Like, so there's loads of overlap in our interests, and yet she's also doing this really super cool research into kind of providing care during emergency extrication for people in space, which is awesome.
Yeah, and I think, we talk a lot about ECMO, Reboa. I think there's a lot of the talks here that are actually not about that. I mean, there's a talk about the dose VF trial.
That was great.
Which I think was really cool. Like, that's a trial that I read in Journal Club in fellowship. And so to have like the primary author be here and talk about what, kind of how he did it, but also how he looked at the results of that. Because I think, some of the things that we thought about, like vector change is the same. He was like, that's like a social media headline. Here's the data and here's how I saw it. I'm like, oh, that actually will change how I think about it. Because when a medic calls in, I'm like, just either vector change, or if you have two, do two, whatever, it's fine. And actually the data says no, dual sequential is better. And so it was cool to like have the PI giving a talk about his like paper that I read in Journal Club,
And his talk was a really, really great marriage of proper hard science. Like, he really, really showed us the data and made really, really coherent argument for why people misinterpret the vector change data. But then he also translated it into reality for us and talked to us about some of the really pragmatic things. Like, I 100% know the kind of biggest barrier around us is people saying you're going to break one of our defibrillators. And he directly addressed that, not only showing us the data that suggests you're not going to break your defibrillator, but also showing us, importantly, that it's covered by their warranties for Zoll and Stryker anyway. Yeah. And it's so pragmatic that that's kind of essential to actually practicing.
I think the other pragmatic thing he talked about a bit and linked to his videos was the strategy for actually doing dual sequence. That was like, you do, I can't remember off the top of my head, but like you do 3 minutes, you put the pad on the back, you do 3 minutes, you put the pad on the front. The next time you do the shock, you're doing dual sequence. Like, it wasn't just, we're going to just try and do this thing. It was, this is how you do it. This is how we do it every time. It's part of the strategy and the protocol and the plan. And I was like, oh yeah, you've made it sound like a very simple process that we could just put in place for everyone. So then if you need to do dual sequence, you're set up, you're ready. Everyone knows that's on the cards and might be something you're going to do. And that was a really nice pragmatic discussion. After, like you said, after the hard science of, look at this data, it really works. He was like, and this is how to make it work in your clinical practice at the roadside, not in an ED where you can just wheel over another trolley. It was very pragmatic with like, you might be waiting for that second ambulance to arrive to bring you a second defib. Yeah. And this is how to streamline that process. So when they arrive, you can be like, hey guys, this is what we're doing. And they go, oh yeah, I remember, this is what we do. That was really valuable for me. I like that.
Yeah. I thought Claire Park's talk was also really excellent and really kind of broadly applicable, even though in some senses her learning point really was quite system level that I don't have power over. She was saying, one of the big fundamental things that needs to change is that the data needs to be made available sooner after these major incidents, including in the UK, when we had the 7/7 attacks, there was very minimal post-mortem, either radiological or pathological post-mortem data into what actually ended up killing people. And I can't change that at a system level in the UK's response to mass casualty incidents. But within her talk, there was so much like really rich learning and, examination of 10-second triage, the problem that penetrating trauma equals P1 in 10-second triage. But in an incident where it's a mass shooting, does that mean everyone's a P1? And the practical kind of solution of having P1 plus. And it was just also really, really cool to hear that criticism of 10-second triage from, again, one of its primary authors and someone who does have real firsthand heavy experience of being in austere environments with casualties, as well as dealing with MCIs in urban centres.
I think for me, the other thing with Claire Park's talk is, so I have read the Saunders report from Manchester and the masses of transcripts from the 7/7 court hearings, and they are hugely illuminating. But that is a big read. And I think having Claire Park turn around and say, reading those is probably the only way to get some of that data, because we are so bad at pushing it out and putting it into academia. I found that kind of reassuring that I hadn't wasted time reading that stuff. Like she didn't stand up and say, "Oh, you could have just read this summary over here." So I would encourage people to go and read those big inquest reports. They're really worthwhile.
Yeah, I mean, even like from the US, we're thinking about like SMART triage and START. And so to even think like hearing about this is the 10-second triage. It was kind of eye-opening. Like, oh, right, stop counting respirations. Like just ask them if they can talk, And so I think that was really cool to see what's happening in different areas. I think we just kind of get so, especially in the US, like US centric, so it's awesome to see what's going on.
And it was interesting. She addressed some of the other decisions like relabeling dead to not breathing from two perspectives, which was one, they've labeled under that, consider CPR if resources allow, because she had a heavy point that there are instances when it is appropriate to attempt resuscitation, even if you are in a triage situation, if you have enough resources. And then secondly, talking about not just from a humanitarian perspective of thinking of responders' well-being, although that's important, but also thinking about actually, even in training, but certainly in reality, people struggle to put that dead label on to other humans, and it delays the triage process. So both from a perspective of looking after our responders and also doing the best for our patients, that was what guided that decision. And it seems like such a small point on the algorithm, but it's so interesting to hear the amount of thought that goes into those things.
I guess being mindful that there are non-UK listeners, so 10-second triage is really worth looking at. It's been rolled out across the UK and it's now multi-agency. So our police and fire will be going around and undertaking primary 10-second triage, which was a bit of a jump, but those organizations have come on board with that. It's been a really positive transition. So then you could potentially have the first ambulance turns up and half the casualties are already triaged, which is amazing, right? That's a whole different paradigm to managing that situation. And certainly chatting to local police and armed police, they are really pleased that they can start making effective patient decisions and assisting people once they've cleared the scene or they've made it a permissive environment. They now have very clear direction of what to do next, which has worked really well for our police.
Yeah.
What are you going to talk about tomorrow, Aebhric? I'm actually excited to hear about evidence for improvised med.
Yeah, so this week I gave 2 improvised medicine workshops. You guys helped with that one. And we had a interesting group. They were hesitant at first, but then they saw the QR codes for the research that we give, and they saw the need for especially the improvised tourniquets. So tomorrow, Tom and I have the front stage, not together, like that would be horrible for me. It's easy for Tom. So I'm going to talk about improvised medicine and some of the research I've done. The article I submitted to the Journal of Special Operations Medicine on pain and tourniquets, and we'll see. I'll just give a kind of a general background of what we normally teach on a day-to-day basis, and Malta, which is not a big deal for us, but doing this with a bunch of consultant anesthetists who have a wall full of kit this is going to be the most challenging speech I've yet given.
Mm-hmm.
What about you?
Be interesting. What are
you going to talk about?
Oh, so my I'm not sure whether my talk is going to ruffle feathers or if everyone will just nod in agreement and it will just be old news. So I am putting forward the case that we should all be doing much more in the way of pre-hospital nerve blocks and pre-hospital regional anesthesia. So there's some really good resources around military pre-hospital regional anesthesia, but from my experience and from chatting to international colleagues, there's certainly room for us to improve in the provision of that humanitarian pain relief pre-hospitally. And obviously it avoids you having to use systemic analgesics. So if you have the choice between ketaminizing a patient, or maybe we could just give them a triple block in their forearm for their massive hand trauma, maybe it's better giving them a nerve block, right? Then they're cognizant, they can talk to you, they can tell you their past medical history, you don't have all the side effects of a ketaminized patient. That's going to be my argument.
So you're going to be fine until you touch that third rail, which is, what about non-doctors doing blocks pre-hospital?
Yeah. So I'm going to sneak up to that. That's going to be near the end. I'm going to direct people a little bit to my colleagues in the Welsh Ambulance Service. I know they've been doing some excellent work with their paramedics undertaking nerve blocks. I'm not claiming to be an expert in the work they've done, so I hope people will go and check that out. But certainly up in Scotland, our advanced paramedics alongside us are undertaking nerve blocks when they're working as an enhanced care team. So yeah, it'll be interesting to see what the audience reaction is to the suggestion that perhaps paramedics could be doing this fairly straightforward intervention.
Sean, you're an EMS doc in Maine. Do you allow your paramedics to do blocks?
Our paramedics don't even have ultrasound yet, and so I think that's a knock on us more than anything. I think that we're behind EMS. The EMS in the US is behind what you guys are doing in the EU. I mean, we don't have advanced care medics. That's not a thing, right? And so we have certain pockets like San Antonio and Miami that are certainly pushing the boundaries and are doing amazing things. We heard Darren Brody, who's at a University of New Mexico, he gave a talk on TEE and the pre-hospital environment, and they're talking about their medics are doing TE currently and moving towards TEE. That's not in our system, and so you do see that in little pockets, but it's not as broad strokes. I think that we go back to this education. It takes so long and so much effort to educate with ultrasound. And we gave the ocular ultrasound workshop the other day. It just takes an amount of energy to understand what you're looking at that I think we need to work on it. It's just, I think that we have a lot of barriers to get us moving towards that. And, a lot of times the docs that respond, I will have one and I can kind of work with the medics on it, but we're at the point where you hand them the probe and we're still not sure what the anatomy looks like in a normal person, and image acquisition is challenging, and then interpretation of ultrasound is hard. It's second nature to all of us, but that skill set is actually really hard. And so we have 4 steps before we're okay. Now here's a needle and inject. I think that it's possible. I think that we're heading there. It's just the inertia is high to get that moving.
And yeah, I think you're right. I think it's that really steep learning curve.
Yep.
And probably I think the gateway drug to that is IV access.
Yes.
Because then you're scanning, you're looking at anatomy, you're recognizing different structures, and you're needling the patient at the same time. And I think once you've done that, the transition to nerve block, where you're not aiming to skewer a tube, you're aiming to go very near a nerve, is a smaller jump. But I think ultrasound in general is such a steep learning curve. You need investment to facilitate your paramedics to do that. There's no reason they can't, but you need that initial head of steam to push that forwards and to help them get up that steep learning curve. And then once they're up there, there's loads of things they could be doing, but it's that initial jump that's the challenge, I think.
I feel like that kind of comes back to your talk, Sean, of clinical exposure being the primary way that we as physicians have learned, even though we spent years in medical school. And, I've had lots of didactic teaching on ultrasound, but once I started using ultrasound regularly for venous access, my ultrasound skills have improved so quickly because I think you have to develop that muscle memory and sort of muscle instinct for when you need to tilt, when you need to scan, why have I lost view? And you get that so quickly when you're pairing your two hands doing that task. And venous access is a task I'm really familiar with. I have to do multiple times every shift. And so it gives me exposure and on exposure. So then when I'm using my ultrasound for basic diagnostics or for other procedures, I've gained this extra instinct and extra knowledge that makes it a lot easier.
Yeah, to be fair, there is one EMS group in Maine that's doing pre-hospital ultrasound for IV.
Okay.
IV starts. So there's a pilot program. They're doing that there. So we're in the process of seeing how that rolls out. I think when you start talking about EMS in the U.S., you're looking at every state has different protocols, and sometimes they're at the state level. Sometimes they're mandated. Sometimes this is a suggestion, but if there's a doc, you can change them. And so we see this with so many different things. So I think that it takes that head of steam. You need an invested person that's going to teach it. And I'm hoping as more EMS docs come into practice, that's what our job really is. Like, it's really cool when I get to turn like the lights and sirens on, but I spend a lot more of my time like educating people on what they can do and empowering them to actually do that. And like, you're not just driving to the hospital, like you're actually caring for patients. And so we're just have to change that perception that you're an ambulance driver. Like that's not what's going on. Like, you're a clinician. Like, and so I think that more EMS focused docs, you change it on the hospital, you change it in for the EMS system itself.
What's interesting is right now, as we speak, in Pretty Bay, Malta, Jason Jarvis and Rod Jordan are bringing out the ultrasounds for the EMT course. So the EMT, the CoROM starts ultrasound as the EMT. Is that completely unheard of in the UK and in the US?
I think it's certainly not the status quo, but then the number of people you hear saying, look, the ultrasound is just the new stethoscope, right? If you give a stethoscope to your EMTs, you give them an ultrasound. These aren't stupid people. Like, if you want to invest in education, they can use the ultrasound. And once they can use the ultrasound, they can use it for so many things. And I think we just still have a cognitive stumbling block where we think it's an enhanced thing. It's a special magical tool that doctors use. It's just another tool, right? We've taught EMTs to do 12 lead EKGs and to interpret them. So why can't we teach them to do an ultrasound and interpret it? I don't think it's not difficult. It's just you need the willpower to approach it and to do that.
Yeah. And even if you're not actively using it every day, I think learning how to wield it, but also what is going on in the body. I think we talk about, like, we don't do dissection in EMS. Like, you don't, like, the three of us spend plenty of time cutting open cadavers as part of med school. That's not a thing in EMS. And so, like, we were doing the fast today, and we were on like the left side, and the medic was like, that's the liver. Oh wait, I think the spleen's there. And so there's these things that are like
less instinctive knowledge.
Yeah, right. And so I think that, like, giving them the ultrasound probe and understanding how to acquire the image, but also like what way is up, like what is anterior,
as a teaching tool.
Yeah. And so, and you understand it in 3D space. Okay, I know where the liver is, and I understand it's right near the kidney, and I get why blood might go there because that's the most dependent part. And so you start putting that together, like, if there's abdominal trauma, where might I start to see the bruising, right? And so I think there's no bad educate or no bad knowledge, right? And so, like, getting more knowledge and more skills, and then empowering them to, like, you can do this. Like, this is a skill set that you can learn. And it starts to break down that hierarchy of, like, the EMT defers to the medic, who defers to the doctor. Like, we start to level that out. And I think it helps the EMTs so much to be like, I got a 12 lead. Like, that's a huge deal. If you really think about it, that's like the data point I need in chest pain. Like, that's the one. And the intervention is aspirin, which you also can give. Yeah. And so, like, a cardiac, like a STEMI is an EMT treatable, like, diagnosable and treatable thing that is life threatening. And also you drive, which means that's time, right? So like that is a BLS.
Mm-hmm.
If you add the EKG, that is a BLS level call of a high acuity patient. So you're not just running low acuity stuff.
Yeah.
Stroke's the same way. Can you do a fast ED or Cincinnati or whatever scale you guys are using? You can teach someone to use the scale. That's actually the data point I need.
Yeah.
And so you think about like, these are time sensitive, high acuity things that at BLS level, you don't need to intubate everybody. Like this is, and you're actually making a huge difference in that patient's life and in the system.
Mm-hmm.
Get the EKG and tell me it looks bad. Now I can wake up the cardiologist who's sleeping because invariably it's 4 a.m. and they can drive in.
Yeah. I guess I should also use this opportunity to plug that I have written a pre-hospital ultrasound logbook and guide, because I think one of the stumbling blocks is ultrasound can do loads of things, whereas that book details the most common pre-hospital protocols. So it is basically put the probe here, you will see this is what you're looking for, and then also provides you a way of logging your learning to show evidence that you haven't just picked up a probe off the street and you're waving it around. You have scanned multiple people, you have correlated it with subsequent imaging, you have developed your practice. So feel free to find that on Amazon. That would be great.
So we have 1 day left, and then I've got to leave right after. I've got to get back down to Malta to teach the TTAMs next week. But this time next year, will you guys be speaking here?
Depends. We're invited back.
Yeah,
probably.
I think that,
That we'll find out tomorrow, won't it?
Yeah.
If I start taking and everyone's leaving, I think that's a good indication that.
I think that PFC course, people left excited. So I think if that information gets passed on, I think that there's a lot that can happen there. And it blows my mind how psyched they were. And that was really basic from what you could actually do, And so I think that if we're able to do that again, I think that would be great.
And it was fun to teach, right?
It was so fun.
Yeah.
So I get to wear my harness and my ski pants at the same time.
Exactly.
Awesome. Well, to the three of you, Ella, Sean, Ton, safe travels home, and we will see you again on the podcast.
Thanks very much.
Thank you.
Thanks so much.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at corom.edu.mt.